Hello everyone, I'm Dr. Prerna Lakhwani. I'm working as Associate Consultant in the Department of Surgical Oncology, BLK Hospital. The cervix is the mouth of the uterus, and it is the abnormal growth which occurs at the mouth of the uterus, which is called as cervical cancer. There is a virus known by the name human papilloma virus or HPV. Viruses having numbers 16 and 18 are the most dreaded ones because they cause almost 95 to 100% of cervical cancer. Cervical cancer usually present with abnormal vaginal bleeding, excruciating pelvic pain which is radiating to the thighs or to the back, foul smelling or blood-stained discharge, or in very late cases, fecal incontinence or urinary incontinence. The more sexually active the patient is, the more chances of acquiring HPV and thus the cervical cancer. Patient with a partner having multiple sexual partners is also at a high risk. Patient is immunocompromised by any reason, say HIV, or if she's on immunosuppressant drugs, she's also at high risk of acquiring cancer cervix. The other risk factor includes smoking, the very long use of oral contraceptive pills, and vitamin A deficiency with this cancer. Diagnosed with the use of a speculum examination, which is done in an OPD, which is called as pap smear, a liquid-based cytology, the HPV DNA test, and even by a visual inspection of cervix by a health attendant in villages. Surgery is the preferred mode of treatment. We can do a radical hysterectomy with pelvic lymph node dissection for the patient. And if the patient presents to us in an advanced stage, the treatment of choice is concurrent chemoradiation. If we grab the disease at the earliest or at its inception, we are able to preserve the fertility also. There are fertility sparing surgeries which can be offered to the patients. If the patient is in very early stage, say microinvasive disease, the patient is treated with the help of simple conization. Or else, if the disease is a little bit advanced, we can offer her a simple trachelectomy or a radical trachelectomy with pelvic lymph node dissection. The treatment depends on the stage at which she is diagnosed and the trimester of pregnancy she is diagnosed with the disease. If it is early, first trimester, and the disease is in pre-invasive or microinvasive phase, the patient can be allowed to continue the pregnancy till term and allowed to deliver normally, and later on followed in the postpartum period for the treatment options. If the patient has the disease in the second or late trimester of the pregnancy, the option left depends on the viability of the fetus. If the baby is viable enough, delivered by classical cesarean section, and at the same time the hysterectomy with pelvic lymph node dissection is done.